Well, some statistics. Presently, about 1/3 of the world's population is infected with MTB, right? And approximately 10 million cases occur every year with 3 million deaths worldwide. So deaths from TB comprise about 25%, that's a large number, 1/4 of all avoidable deaths in developing countries. In India, it's a major public health problem, we all know that. 1/5 of the global TB incident cases are in our country. And out of this population of over 1 billion, that means each year nearly 2 million people develop active disease and up to 500,000 die, and that's a lot of numbers. So it implies that death occurs every minute due to TB in our country. And this is just some world statistics where, India is, along with China, shares that red division. Well, now that we focus on TB in the ICU, TB in the community or TB in the ICU, basically it's all infectious. The only reason why we need to be careful when it comes to a healthcare setting is that it spreads to healthcare workers. We have, with all the accreditations that are there, we need these airborne isolation rooms, which cost a lot of money. And because they cost a lot of money, there are only 1 or 2 or 3, even in the best institutions in the country. So we need to obviously diagnose our cases fast so that we can start treatment fast, contain the disease, prevent its spread, and treat the individual patient. So that's what this slide even says, which was said even many years ago, as early as 1995, and we're still talking about the same thing. TB has various forms, you know that. It can affect any organ of the body, pulmonary, extrapulmonary, and we're not going into that. It can be active, it can be latent. The focus is on diagnosing. There are various modes of diagnosis, but we're going to be talking of microbiology diagnosis today. And microbiology diagnosis, there are indirect methods where you can detect antibodies for mycobacteria, and there are direct methods where you can detect bacteria and its products. We're not talking about CT scan, MRI, and the others. So indirect methods, briefly, there is antibody detection and there's antigen detection. And all I just want to say is that please do not use ELISA for diagnosis of TB. It's not recommended. The direct methods is what we're going to focus on a little bit. And we have direct microscopy, right, which can be done by various stains. Culture methods are there, and there is detection of the nucleic acids by DNA or RNA of the mycobacterial origin. So we'll just briefly go through all this. We're not talking about latent infection by diagnosis by TST, that's the tuberculin skin test, and we're not talking about interferon gamma. That's latent TB. We're more concerned with the active TB, which is going to spread to the patients in the ICU or in the hospital. So we're going to focus on smear examination, culture, and the identification. So coming to microscopy, Z Nelson stain, that's the ZN stain which everybody sends out their samples for. Okay, please do an AFP stain. That's the commonest one used. It's easiest, it's quickest. However, it has limited sensitivity, but the specificity is virtually 100%. There's another one, that's fluorochrome staining, which can be done, which has a increased sensitivity and can be examined in a shorter time. For ZN staining, you've got to have up to at least 10 to the power 5 bacteria per ml for the lab to pick it up. And it does correlate well with the extent of disease, with the presence of cavitation, with the quality of the specimen, and it's a good marker for infectiousness. So it's inexpensive as well, right? The only limitation is its kind of less sensitivity. However, sensitivity can be increased when pooled serial specimens are used. This is just a similar thing to just tell you that it can be used for pulmonary as well as extrapulmonary, though Faucet has limited role in extrapulmonary cases of TB. So now coming to culture, there are various ways to culture, and this is just the way the microbiology lab would do it. Start with the sample which comes and decontaminate it and culture in the appropriate media. The traditional culture, which was the Lowenstein-Jensen medium, that's the LJ medium which was taken, usually done, the oldies studied it that way, and now the youngsters probably talk less about it, is that it's more sensitive and can be positive even when the bacterial load is low, that's 10 to 100 bacilli per ml. So sensitivity of 80 to 85% and a specificity of 98% is very good. It is, however, required that you culture the organism for a precise identification and susceptibility, whichever way you do it. Now, the traditional way is slow, takes up to 6 to 8 weeks, and a similar period would be taken for the identification and the sensitivity testing. So it's a lot of time. It's tedious, And so because of that, liquid cultures have emerged, and these liquid culture systems reduce delays, right? It can be done in as little as 10 days versus the solid media. They are also more sensitive by approximately 10% over the solid media. And however, they are prone to contamination. Even in experienced laboratories, approximately 5 to 10% do not yield results because of contamination. So these are just some of the liquid media like Bactec and Midget, which are commonly used, and I've just highlighted that. The identification of the organism depends on the rate of growth, the colony morphology and the pigmentation, and then there's a battery of biochemical tests which can be done. This is what the colonies look like. The ones on the left are the smooth buff-colored colonies suggestive of Mycobacterium avium, and the rough buff-colored colonies suggestive of Mycobacterium tuberculosis. So just a comparison between the solid and the liquid, that's the Midget or Bactec. The solid is highly specific. However, even the liquids are highly sensitive and specific. The only disadvantage of the solid media is that takes longer, and the ones on the liquid media are faster. Also, they're particularly useful in extrapulmonary TB. This is just a picture of the Midget, how the system looks and how you put it in, and how a whole battery of tubes would be looking in the equipment. So reporting out of TB cultures is based on the method you use. The positivity depends on the type of specimen, the treatment status as well, the number of organisms in the original specimen. Obviously, a large inoculum would obviously lead you a better result. But a negative report cannot be released before 6 weeks. And so microscopy is less sensitive as compared to liquid media. This is what this reveals. So all these conventional TB tests, however, people felt there was a need for upgradation. And so there was an interest in a lot of new tools. And if you see this new diagnostics pipeline, whether it's antigen detection tests or it's microscopic visualization or it's culture-based growth, nucleic acid amplification and others, there's a whole battery which is now available. Light emitting microscopy is more sensitive. And coming to what I would like to now focus on is these newer methods which are less talked about, but which are faster. And that is the detection and identification of mycobacteria directly from clinical samples using either genotypic methods or phenotypic methods. So PCR, you've heard a lot about PCR and generally for others. So I just want to briefly highlight, in pulmonary TB, it detects merely all smear-positive and culture-positive cases and is useful for rapid diagnosis of smear-negative cases of active TB. In extrapulmonary TB, it has a limited role. It's a valuable adjunct, however, in the diagnosis of tubercular meningitis, pleurisy, pericardial TB, and other conditions in which the yield of other tests is low. However, remember, it needs a high degree of quality control. So if not in good hands, you would get high number of false positives. And obviously, there are variations from lab to lab, so you need to obviously use a good lab for when you use this test. In patients on anti-tubercular treatment, it should not be used as an indicator of infectivity. It is important to remember, as this assay remains positive for a greater time than do cultures. Then there's this LAMP, which is loop-mediated isothermal amplification. It's based on an isothermal technique. It's a novel nucleic acid amplification method. And it's used for the detection of Mycobacterium tuberculosis complex, M. avium, M. intracellular from sputum specimens, as well as it can be used for culture isolates which are grown. Then transcription-mediated amplification and nucleic acid amplification are techniques which are chemical rather than biological amplification, give results within a few hours. And they're currently used only for respiratory specimens. Ligase chain reaction is a variant of PCR in which a pair of oligonucleotides are made to bind to one of the DNA target strands so that they are adjacent to each other. And it's mainly used for respiratory samples. There's a high overall specificity and sensitivity for smear positive and negative specimens. There's also a phage-based test, which is called fast plug TB. It's a rapid manual test, and there are other phage-based tests as well, which are available. Anyway, if you compare PCR with smear with culture, you would obviously find PCR more rapid, more sensitive, and can differentiate even between typical and atypical mycobacteria, which smears can't obviously, but cultures can. Once you've identified the organism, you obviously need to do drug sensitivity testing. which is initially obviously to be performed on the initial isolate from all patients. So you need to differentiate between primary and acquired drug resistance and confirm the choice of the initial course of chemotherapy. However, you need to repeat it if the patient remains culture positive after 3 months of appropriate therapy or shows clinical evidence of failure to respond to therapy. By the traditional method, we've said it takes 6 to 8 weeks, but the current WHO or College of American Pathologists recommendations for releasing the TB direct sensitivity test is 28 days. And however, it's possible with the battery of 13 drugs as per WHO recommendations to give it within 15 days. We'll now talk about drug resistance, because once you've had this, there is a lot of drug resistance in our country, and it is to the tune of 0.5 million multi-drug resistant, and extreme drug resistance is also rising. We all know that. So what is multi-drug resistance? It's defined as TB resistant to at least INH and rifampicin, with or without resistance to any other drug used for the treatment of tuberculosis. Extensive drug resistance, or XDR-TB, has been defined as TB resistant to a fluoroquinolone, that's ciprofloxacin and others as mentioned below, and any injectable second-line drug like amikacin, captomycin or kanamycin, in addition to INH and rifampicin. As per WHO 2010 global report, we have more than 50% of MDR-TB cases worldwide are estimated to occur in India and China. So that the TB load is to the tune of 2.5 lakh cases. And that makes it around 3%, with even acquired MDR being to the tune of 12 to 17%. And so we must take drug resistance obviously very seriously. There's just some more statistics which will tell you that 131,000 MDR-TB cases, that's the last, emerged in India in 2009. And so, if not vigorously addressed, and though the WHO had declared this a global emergency in 1993, we're still having this problem of multi-drug resistance in TB. This is just some statistics which shows you about various states, what they've done. So Gujarat and Maharashtra in 2005 and 6 showed that it was 3% among new cases and 12 to 17% among retreatment cases. Even XDR-TB has been described. We've gone through the definition. And so we come to the diagnosis of drug resistance is obviously based on a sputum culture which grows either slowly in the solid media or by liquid media you get a rapid growth. These are called molecular drug resistance tests, and recent advances have occurred in its understanding, leading to the development of rapid DNA-based molecular tests to detect mutations associated with drug resistance. So if a mutation is thought to be associated with resistance detected, then the bacteria are considered drug resistant. If no mutation is detected, bacteria are assumed to be drug susceptible. And I repeat that it's an advantage that you can get this result within 24 to 48 hours. This is just how the test is done. Its DNA is extracted, there's PCR amplification, then the products are hybridized, and they are then with oligonucleotide probes, and then they are captured. Labeled hybrids are detected by colorimetric development. This is just a diagrammatic representation of the test steps to be done, and this is how the results appear. Of course, they have to be read and interpreted by obviously people who are more used to performing those tests. Commercially, these tests are available from Hind Life Sciences, and it's called MTVDR, which detects the presence of TB complex and mutations associated with rifampicin and INH resistance. And when it is for rifampicin resistance, it's to the tune of 98% sensitivity and 99% specificity, as reported by Ling et al. There is much less has been developed for other TB tests, anti-TB drugs. And when it comes to isoniazid resistance, the sensitivity is to the tune of 85%, whereas specificity is 99%. The critical contribution of this, of course, slightly expensive nucleic acid test is, but in the scenario of multi-drug resistance and XDR in our country, is the earlier detection, reduces time of detection, and also reduces time for TB diagnosis to start of treatment. And starting treatment, you're treating the individual patient, containing that patient's infection, making him or her less infectious to another patient, and as I said, even be able to treat fast and shift out fast, either from an airborne isolation room, which is a kind of a mandate these days, or even from the hospital. And even out of the community, a less risk to the public at large. These rapid diagnostic tests can be done on all sputum positive. It's basically respiratory samples which have to be done. In case of failures, that is sputum positive, defaulters, or those taking drugs irregularly, and all TB patients co-infected with HIV or diabetes. Because I just want to conclude by saying that obviously if we delay diagnosis, not only that individual patient, we do not able to treat first, it also is, so not only increased morbidity, there's also increased mortality, and patients would be improperly treated until the results are back. Further resistance can occur, and even the second line may be lost. And obviously patients continue to spread this resistance strain, and we'd probably be dealing with more and more, higher prevalence of resistance to TB in our country. These are just some of the essays which are available. And these are some of the references. So to conclude, we have these conventional tests which, give results by smear in 24 hours, but that's obviously not the growing the organism, nor having the identification, nor having the sensitivity which you would require. And so there is this role for liquid culture, which gives you a rapid diagnosis, and role for these nucleic acid amplification tests, which can give you the results of, obviously on a grown, mycobacterium within 2 days. Thank you so much.